And that is why sir said that early mobility is the solution. It also causes osteoporosis and cartilage degeneration, and the ratio is 1:4. The strength lost in 1 week will take as much as 4 weeks to recover. So somebody who is forcefully bedbound for 3 weeks, it will take months. So this is one picture. You can appreciate the intercostals have all atrophied. There is also a lack of nutrition of this patient, and there are also postural contractures in his hips. On the cardiovascular system, postural hypotension occurs often in a person forced to take bed rest. There's also an increase of resting heart rate. So this causes a loss of the physiological adaptation to more activities later on. There's an increase in stroke volume as well as a left ventricular end diastolic volume. The blood volume is seen to increase by 7% at 20 days, and there is also an increase of cardiac size gradually. For the respiratory changes, we have seen that there is wasting in the intercostal muscle, as well as the range of the costovertebral and costochondral joints reduces. This reduces the strength of diaphragmatic, abdominal and intercostal muscles, leading to a weaker cuff effort. Atelectasis occurs, and also the mucociliary clearance is reduced. Delirium is very common, and it can occur at any point of time. Inattention, decreased awareness of environment, a change in cognition, and they have delusion, emotion. One of the strongest predictors of death and long-term cognitive impairment. And as sir has said, we normally think of delirium as something hyperactive. And some patients are drowsy, but they are not drowsy. They can be having hypoactive delirium. We need to identify that. And the mixed type is more common, where they're alternately hyperactive and hypoactive. So onset on day 2, duration is usually 4 ± 2 days. This is Western data. 50% of ARDS patients will be still delirious at ICU discharge, and 10% would be delirious at hospital discharge. This is increased with an increased risk of death in the next 6 months, and an increased length of ICU stay and hospital length of stay would increase the costs. And early detection is possible by many tools. One of them is the CAM ICU. So there's a Richmond agitation sedation scale. We'd like our patients to be between +2 and -2, and those above -3 right up to +4 if possible can be subject to the CAM ICU questionnaire. It can be administered less than 1 minute by the nurses or by a trained nurse, and it has been translated to 26 languages. For those with a low score, -4 or -5, the coma stimulation program should be done to raise their scores if possible, and then we can see whether the patients have delirium or not. So this confusion assessment method in the ICU consists of these 4 questions. For those who are hearing impaired or have difficulty maybe in cognition, something like these pictures can be given. 5 pictures are shown to the patient for maybe about 1 minute, one after the other, and they are taught to nod yes or no when the next set of 10 pictures are shown. So if they find the 5 pictures that they have seen common in these 10 pictures, they'll say yes. If they don't, they'll say no, and this is scored. Non-pharmacological protocol also includes to make them sensorily aware, provide their spectacles, provide their hearing aids so that they may hear and see properly, encourage communication with the patient and reorient them repetitively. This is the date, this is the time, your name is this is this particular hospital. The nursing staff allocated to this patient would be this same lady or same brother. Allow television, daily newspapers, non-verbal music, maintain a strict sleep hygiene, create the condition where the patient may sleep at the proper sleeping time. So this will help to restore the circadian rhythm, and mobilize early and often. Try to decrease deep sedation. If possible, provide a sedation holiday. Drugs, sir would be more expert at that. Avoid benzodiazepines, maybe use dexmedetomidine. Possibly haloperidol has no role in ICU delirium treatment, but risperidone, olanzapine and quetiapine shows promise. Treat the underlying metabolic causes, the dyselectrolytemia, the infection, and try to maintain a systolic blood pressure of at least 90, an SpO2 of 90% or more, and control any underlying pain that might be there. So CIP, critical illness polyneuropathy and critical illness myopathy, they are quite similar symptoms. They are overlapping, and diagnosis is difficult individually. You might need an EMG NCV or muscle and nerve biopsy. And this was identified by Charles Bolton as early as in 1984. The cause is unknown, but it's guessed that possibly it's a neurological manifestation of systemic inflammatory response syndrome. Corticosteroids, neuromuscular blockers, as well as conditions such as hyperglycemia and hypothyroidism might occur. And 1/3 to half of the patients in the ICU staying for more than 7 days would be susceptible to CIP or CIM. There is a generalized symmetrical muscle weakness affecting the proximal muscle. So it affects the patient's mobility, the ability to get up from bed, use his or her hands to just lever himself up from the bed. The facial muscles are usually spared and ophthalmoplegia is rare. There may be difficulty in weaning in these patients. This can prolong weaning time of mechanical ventilation. We may see decreased and the peripheral nerves are usually affected. The CNS is usually spared. So solution, again, sir has said, early mobilization includes progressive therapeutic exercise. So many of the journals have supported this to mobilize or not to mobilize. The means there is no risk of an adverse event. Yellow outweigh the risks, and red means it's better avoided. So for many conditions, there are this, you can just keep a list of this on your table, and for endotracheal tube, for different types of respiration, for neurological conditions, for other post-surgical conditions, cardiological, respiratory conditions, you have all these. And summarizing, what are the absolute contraindications for in-bed exercises? If the patient is very agitated or combative, a RAS score of +2, more than +2, an increased intracranial tension which is actively being managed and not yet stabilized. There is spinal instability. Its fixation is not yet done. Uncontrolled seizures are there. The patient is on antihypertensive management or in an hypertensive medicine currently. There is bradycardia requiring medication or awaiting pacemaker. For COVID and other things, we have seen that the patient is in prone position, so better not raise the metabolic oxygen demand, and there is an uncontrolled bleeding. So there are some relative contraindications for out-of-bed exercises, but you can do for the in-bed exercises. The challenges have sir has highlighted. There's a lack of orientation in some doctors. There's no rehabilitation concept initially in the nurses. We need to include that in the nursing curriculum as well. And again, the nurses are also very much stretched in the ICU. They have hardly time to administer this CAM ICU protocol or other questionnaires. Some admitting consultants are worried about costs in the open ICU. There is sometimes a conflict between the nurses and physiotherapists who shall be doing the positioning, suctioning, etc. Sometimes the availability of the proper rehabilitation equipment, maybe the ergometer on the bedside, is an issue. And the moment we have trained some doctor or some nurse, they get a better job, or the nurses get a government job and they leave. So this rate of attrition also affects the quality of care. So when with Dr. Dimita De, I had started this program back in 2015, we had achieved some successes which are documented over here in pressure injury reduction. So some atelectasis which was removed by some sessions. This is a patient of pancreatitis who had stayed with us for almost 4 months in the ICU. Finally, he was able to be mobilized and he returned just to say thank you. So these are some other pictures. And impossible is nothing, because These are some old pictures from Johns Hopkins where they show people mobilizing even with the ventilator on. This has started in some of our ICUs. So this is a portable ventilator and the patient is mobilizing in the corridor of the hospital. So how to create this awareness? You advertise everywhere. At the entrance of the ICU, at other places, that early mobility is important. Ambulation outside the ICU, bathing or taking a shower of ventilated patients, use of TV, iPad for sensory stimulation, and a greater role of family members, that ABCDEF portion is a way to go in the future. So some of the nurses have made that how the family can help. We can take a questionnaire and involve them actively in these sectors. So the summary is that early mobility and involvement of rehab services early, as soon as hemodynamic stabilization is there, is beneficial and cost effective for the patient. Thank you so much for the patient listening.
So I related do not have questions, but yes, I think a lot of awareness is still important in terms of critical care rehabilitation. And awareness, we have not included, or we have probably included, the administrators in the group who think that one physiatrist is good for the hospital, the whole hospital. So forget about dedicated critical care, not only in the government sector, but also in the private sector. 2 physiotherapists for the whole hospital, right? And we are expecting physiotherapy twice daily in ICU, at least twice, no, even more. We want somebody to be there all the time, right? Whenever the patient is a bit awake, we want them to move, right? And so that becomes a practical problem, that when somebody is in, or when somebody is in to assess them or to treat them, they might be having their food and on and goes away. So the whole day goes away without mobilization. So those are the things where really the cost implications have to be made. We have to make people understand. Not only the awareness, you see, that's very simple. Everybody wants awareness, but without cost. And that includes the society, those we're talking about, the administrators. I mean, everybody it needs. So, but we need to ultimately put the cost perspective and see that it is actually cost effective. And that is how probably we can increase the scope of services. So that was my comment on.
You please comment what happened.
Yeah, I do agree. For all members of the rehab team nurses, this awareness should be there, definitely. Yeah.
Yeah, thank you. It was nice to know that you can rehabilitate a patient with ventilator on. That's a learning for me. Thank you.